First of all, I just want to say good afternoon to everyone and thank you for allowing me to participate. Certainly want to thank the organizers of this meeting and Rajendra Gupta, who's done a tremendous amount of work of making sure this was well organized, and Professor Ganapathy, who's really been my counterpart as the current president of the Telemedicine Society of India. I'm the immediate past president of the American Telemedicine Association, and it's actually my third trip to India, and I am really impressed by the progress that's being made in your country. I think we have a lot to learn from India, and hopefully we can continue this wonderful collaboration in the international community. So if I could get the slides started here. Same laptop. Yeah, same laptop. Presentation's right on there. I don't know. Before, as we get to this presentation brought up, one of the things that we do in our center, I'm the medical director of the Center for Telehealth and Cybermedicine Research at the University of New Mexico. And we face very similar challenges. We're a large rural state, as I'll show here. I think we're ready to go. And
it is the right one.
You had it correctly. Great, thank you. And one of the things we do at our center is we are there as an incubator. And a program will come to us, whether it's neurosurgery or it's primary care or other specialty areas, and we will do the technical planning with them. What's the most appropriate, affordable technology to meet the need? We do an operational plan. Who needs to be at both ends? How will it be scheduled? How will you document the encounter? What other information might you need? We then also ask them to do a business plan, because we realize that many programs with good intentions, without a good business plan and due diligence, can't be sustained. And then the fourth thing that we do is ask them to develop an evaluation plan. What are going to be your measures of success? So I'd like to present Project ECHO, which is the extension for community healthcare outcomes that was developed through our office, our center, by Dr. Sanjeev Arora. He's a professor of medicine. He's a gastroenterologist and liver specialist in internal medicine at our university. And first of all, just greetings from Dr. Sanjeev Arora, who wished he could be here, represents his team that has moved this project forward in a very meaningful way. Just so you know, New Mexico is the 5th largest state in the United States. We have nearly 2 million people, 40% Hispanic, a lot of ethnic diversity, about 10% Native American, a high poverty rate, and greater than 22% of our people lack health insurance. Does this begin to sound familiar with the challenges one might face in a country like India? 32 of our 33 counties in New Mexico are listed as medically underserved areas by our government. And in fact, 14 counties are designated as health professional shortage areas. We just don't have enough providers to go around to meet our needs. We have a maldistribution of health specialty providers in New Mexico, and most of the specialty providers are within those circle areas in our state, and quite frankly, the major number are in Albuquerque, New Mexico, where our university is, where most other communities do not have the depth and breadth of specialty services. Very, very similar in a way as you might think about in any country or developing country. So we have critical gaps in health expertise and services in our state, with this maldistribution of providers, lack of access, and as I've mentioned, only 3 of our 33 counties exceed the national average of physicians per 100,000, and 64% of our physicians practice in 3 of those counties, yet those counties only comprise 39% of New Mexico's population. I heard earlier today that this is even more profound in India. When you look at the number of people in rural villages with a mismatch of the number of providers for care. So clearly, telemedicine, e-health can play an important role in improving access to care. So let me talk to you about Project ECHO, the hepatitis C story and beyond. Dr. Sanjeev Arora came to us a few years ago and said that in New Mexico that they knew of, there were greater than 28,000 people that we knew were hepatitis C positive, and that's just those that have been tested. But yet, less than 5% were being treated. And if you know anything about hepatitis C will lead to end-stage cirrhosis and liver cancer. 25% of the people will die without treatment. It's one of the highest rates of chronic liver disease and cirrhosis deaths in our country. And this is a global problem. And if you look at hepatitis C all over the world, the intensity of this problem is immense. And yet most of us as providers were never trained about hepatitis C. It was A or B or non-A and B. And not only that did we not know much about it, but the treatment was something foreign to most of us. And yet, with treatment, the good news is it's curable. It is the form of viral hepatitis that can be cured. And depending on the genotype of the strain of the virus, anywhere from 45 to 81% cure rate with appropriate treatment. The bad news is the treatment's prolonged. There can be severe side effects, as you can see, anemia, neutropenia, and depression. It's interferon, ribavirin, and some new medications that are arising. But it is a curable disease that without treatment can lead to death. So Dr. Arora decided to do a hepatitis C trial in New Mexico to see if he could now manage these patients. It's over 30,000 now that we know of, and Dr. Arora said, I cannot see, I'm one of the few liver specialists in our state, I can't see 30,000 people in a timely manner. So I have to look at a different paradigm, and I think telemedicine could be that. So his objective was to train primary care providers in rural areas and in the prisons where there's a high incidence of these kinds of diseases like hepatitis C. And prisoners don't stay in prison forever or in jail forever. They come back into the community. So he said, I think that I could teach the primary care providers about hepatitis C and how to treat it using telemedicine technology, multi-point video conferencing and the internet to leverage scarce healthcare resources. And that's the whole idea. How do we take resource-limited areas and provide them to a limited resource? And then he wanted to show that that care is safe and effective as that would be given if he saw the patients physically face-to-face in our clinic. And to show that through Project ECHO he could improve access to hepatitis C care for minorities who are generally underserved. So we began this project using this kind of technology. This particular pilot program identified 407 hepatitis C patients who met the inclusion criteria. You can see the breakdown here. And basically, he treated 146 of those patients in the clinic as we normally would have. And then he had another 261 patients who he did through telemedicine. And his principal endpoint was to see if he could have a sustained viral response, that is, no detectable virus 6 months after completion of treatment. Could he do this through telemedicine in rural communities with primary care providers as well as he could with his specialty team? Here's the results, and this is published in the New England Journal of Medicine, and I would encourage you to read that article to understand in greater detail what happened. But when you look at genotype 1-4, with the ECHO clinic, 50% sustained viral response. In other words, the virus was gone from the system. At UNMH, it was 46%, no difference, comparative effectiveness. And if you look at genotype 2/3, there was a sustained viral response rate of 70% using telemedicine to the ECHO model, 71% through the clinic, no difference. So we have comparative effectiveness using telemedicine as good as if the patients were seen physically face-to-face. And then if you look at the knowledge and skill and abilities of the primary care providers, if you look at what they felt their overall competence was in treating hepatitis C before the ECHO project, and using 1 as none or no skill and 7 being an expert that could teach others, the rating went from 2.8 to 5.5, highly significant, showing that the primary care providers now through telehealth were much more confident in managing this disease. If you look at a survey that was done at a recent meeting that he held, these were the major points. That the ECHO project diminished my professional isolation. I was more part of the medical system, and we've heard about this through the day. How do we bring the primary care providers and the whole spectrum of providers into the system in a collaborative way? That it enhanced their professional satisfaction. No longer were they isolated, they felt confident in treating this disease. That there was good collaboration in Project ECHO, which was a benefit to their clinic and their rural community. That Project ECHO expanded access to hepatitis C treatment for patients in their community in a way that never would have been done before. That access in general to specialist expertise and consultation is a major area of need. And that access to the hepatitis C, HCV specialist expertise and consultation was a major area of need for them in their clinic. These were highly, highly significant changes after Project ECHO. So the conclusion was that rural primary care clinicians deliver hepatitis C care under the aegis of Project ECHO that is as safe and effective as that given in a university clinic. And Project ECHO improved access to hepatitis C care for New Mexico minorities. So the benefits were also included. There were no-cost continuing medical education and nursing continuing education unit credits, professional isolation, and interaction with colleagues was similar, and though there was less isolation. And there was a mixture of not only doing the work, treating these patients, but learning about the disease to begin with. We also gave them, Dr. Aurora gave them, official hepatitis C virus certification. They were now a certified provider, and that they had access to this whole team. It wasn't just Dr. Aurora, but a team of gastroenterologists, psychiatrists, infectious disease specialists, pharmacists, and patient educators. How well has this model worked in hepatitis C? There have been 500 telehealth clinics conducted at the time before I came here. There are greater than 5,000 patients have entered into this management program, and you can see over 6,000 continuing education credits at no cost to the providers. So I wanted to close with this, that there's an ongoing ECHO mission. The mission of Project ECHO under Sanjeev Arora's leadership is to expand the capacity to provide best practice care for common and complex diseases in underserved areas and to monitor outcomes. This is a model that can be applied anywhere in the world. He points out that this idea of sharing knowledge through telemedicine for these complex diseases fits with this whole issue of developing a knowledge network, that the amount of medical knowledge is increasing exponentially, yet our learning capacity is limited. So there's an increasing gap on the amount of information there and how much we can actually remember and learn. And so telemedicine can play a role. So he's expanding this model to use the technology of telemedicine to leverage scarce healthcare resources, a disease management model focused on improving outcomes by reducing variations in processes of care and sharing best practices, case-based learning, co-management of patients with specialists, and you learn to do by doing. And all these things are what we call HIPAA compliant, that is, honoring patient confidentiality and privacy, using a centralized database to monitor outcomes. His next steps are to train physicians, nurses, pharmacists, educators in many complex common diseases, using web-based softwares, what he calls iHealth, Internet Health, conduct more telemedicine clinics, creating this knowledge network, initiating co-management where each provider learns from other providers as well as the specialists, what he calls learning loops, collect data and monitor outcomes centrally so we can really measure outcomes, the bottom line, and assess the cost and effectiveness of these programs. His disease selection criteria will be common diseases, management that is complex, involving treatments and medicines that has high societal impact on health and economics, and addresses serious outcomes of untreated diseases, those diseases that without treatment lead to bad outcomes. He has a number of clinics that now expand beyond hepatitis C, cardiac risk reduction, asthma, and so on, prevention of teen suicide, and you can see the list there. And the potential benefits, obviously, of the health system in closing are quality and safety, rapid learning, reduced variations in care, unnecessary variations in care, access for rural and underserved patients, reduced disparities, workforce training, the so-called force multiplier that we've heard about, and improving professional satisfaction retention, supporting the concept of the patient-centered medical home, cost-effective care, avoiding excess testing and travel, preventing costs of untreated disease, such as the need for a liver transplant or dialysis, and integration of this model into public health and a new treatment paradigm. And just so you know, they're replicating this model in other universities in the United States, the University of Washington, University of Chicago, and the Veterans Health Administration, and now in India. Dr. Arora, who wished he could be here, is expanding this model here in India as well of how we help primary care providers manage complex chronic disease. So again, from Dr. Arora and his team, from our Center for Telehealth, where the program was incubated, we send greetings, and we hope that this model is something that can be incorporated here for rural health care using telemedicine. Thank you very much.
Dale, what I'd request is for at least one question right now, because we just don't need to make up for some time. But I would request any questions right now.
One of the things, I think if I understand the question, you're asking about the use of video conferencing. One of the things we're doing as you're trying to do in India is improve broadband connectivity to all areas of our state, yet there's still some lack of that. So he's provided actually even the process of, if you can get on the internet, of actually interacting with the team even if we can't see you. Because it is the primary care provider that manages the patient. They do a case review, they provide advice, does further testing need to be done, and then use best practice evidence-based protocols to then manage the patient. Then with side effects, they can come back regularly to this telemedicine clinic and discuss those side effects, determine how best to manage the patient. Is the patient suffering from depression? What do they need to be on medication so they can tolerate treatment and finish to a cure? So he's using video conferencing, he's using the web when they can't do two-way interaction, and in some cases even use the phone where at least they can discuss the case. The visual interaction seems to be more engaging, they can share data visually, but it isn't critical to be able to use this model.
That more seriously as a medical thing. The person next to them only has to explain to them how is it for a patient there, what does the patient feel regarding teleconsultation.
Well, just to finish,
instead of patients face to face, what is the meaning?
Well, one of the things, because this involves their primary care provider, it's their primary care provider that's providing the treatment. So the patient actually isn't even there during the encounter. So what Dr. Arora's doing with this team is providing the knowledge to their primary care provider who they trust and work with on a regular basis. So they do the treatment, not Dr. Arora. He gives the advice, and they do the treatment. And then that primary care provider can go back to the clinic and say, my patient's having some problems. What should I do under these circumstances? So we have that trust that the patient feels satisfied that their primary care physician has got now the capacity to treat them locally.
Okay, I think that's... Dale, please don't leave. We need to give you your memento.